Hello and good evening, and thank you for joining us here live in Ballybuffet in County Donegal. And I am delighted to be joined tonight by Dr. Monaghan, Dr. John Monaghan. And I'd like to welcome you all back to Breaking the Consensus. So, Dr. Monaghan, start at the beginning, shall we? Where does, long before we were ever a doctor, when a doctor was delivering you, where were you? Where is your family?
Where did I spring from?
Where exactly?
And how did I get here?
Yes.
I don't know how I got here. Well, I was born in 1953. I grew up in Navan in County Meath, outside of Navan, on a farm. My father was a farmer. And I suppose went to primary school in the De La Salle Brothers in Navan, which was a pretty tough regime. Got a county council scholarship from there, where I went to secondary school in Blackrock College in Dublin. After that, in 1970, I went to Trinity College in Dublin as a medical student.
So, you come from a farming background.
Correct.
Do you have siblings?
I have an older brother, and he got the farm, of course.
Right.
And a younger sister who's a year younger than me, and she lives in Roscommon.
Very good.
So there's three of us.
So, you say you got a county council scholarship from the De La Salle was the primary school.
Primary school, yes.
But
Yes.
Navan is famous for classical school, isn't it?
Yes,
The grammar.
yes. I don't know why my mother didn't send us there, but it was her decision. I think she was trying to get us off the farm, maybe.
So
but
you must have been a bookish child. Well, you were intellectually a gifted child, but were you bookish?
Not particularly. I liked reading. I suppose I spent a good deal of my childhood without television. Irish television came along in the early 1960s, and we didn't get it for some time. So I suppose people of that age had a habit of reading. I suppose one of the things that I recall as a maybe secondary school student was looking at the Encyclopedia Britannica, which was the Wikipedia of its day. And if any of you ever looked at it, it had sort of fold out pictures of the human body.
Yes.
Which was maybe sparked my interest in medicine. Where's the heart, where's the liver, and all that sort of thing. That may have sort of sparked my interest.
Your first encounter with anatomy.
In the human body. And I think a lot of people who go into medicine might be influenced by experience of illness in the family or something like that. That might have.
Did you have that in your family?
Not particularly, but I remember relatives dying, and I remember praying that they would survive, and they always seemed to die. And I suppose maybe the idea of people being sick and curing them. I remember deciding when I was about 14 that I knew the cause of cancer.
Right.
It was the carbon molecule. If you ever did chemistry, there's carbon and molybdenum and all these. I decided it was carbon, and I remember trying to do an experiment on myself. I said, I'll induce cancer in myself, but I won't let it go too far.
Okay.
So what I did was I got a razor blade and I started to cut the skin off there, and I said I got some soot from the chimney and put it in under the skin. Now, first of all, it was very painful, much more painful than I anticipated.
Right.
And then it wouldn't go in properly, but I got it in and I left it there for a while, but then the skin came away. So it didn't work as an experiment, and I don't think my
was in
theory
school?
was correct either. I think I would have been 13 or 14 years of age.
When you were carrying out the experiment, were you in Blackrock?
No, I was at home
you were
at
at
the
home.
time, maybe
And
on school holidays.
Did anybody say, John, what's going on with the arm? Because I would love to have been there when the explanation. Well, you see, I've discovered the cause of cancer.
It was not observed by anybody. In fact,
No.
I'm not sure if I ever spoke about it until now.
Really?
But anyway, I suppose that's sort of general interest.
So you go from Meath to Blackrock.
Yes,
So you go from the home. You go to the home of rugby,
correct.
and scrum half.
I always usually put out on the wing because I was pretty useless. It was a big school, 800 pupils, and there were only 15 stars, and they were the ones who played rugby.
And how big was rugby, though? Did it really impact
It
on?
was the overpowering, it was the overwhelming ethos of the school was
Really?
we are rugby. They had won 50 senior titles. Next biggest was 10 or 12. So it was a huge part of the school, which I didn't appreciate very much at the time because I wasn't much good at it. But it was a good education, I think. My brother and myself were both there, and we didn't like it that much at the time. But I think it did give us a good grounding, good broad education. I think one of the good things about the Irish education system is that it is broad right up to the end.
It avoids that specialisation.
Yes, into 2 or 3 subjects
Yes.
where you know nothing but science or nothing but humanities or something like that. So it was good, and I went into university then with a fairly broad, more humanities-based than science-based.
But with the intention, when was that moment? Was it when you were 14 that you said, medicine, that's what I want? Or I remember we talked to Patricia Casey, and she said she remembers all these men coming in with split heads to get stitched up after the match, and her mother was the local nurse, and she would have to sew them up.
Yeah.
And I thought that must have planted some desire to heal heads, figuratively. But was there a moment for you?
There was no great epiphany, I don't think. No, I think it came to, when you come to your junior cert or leaving intermediate cert as it was at the time, I think one was coming towards trying to make a decision.
Yeah.
And I think it was, my sister had some influence on it, I think. She was sort of hinting that maybe I should consider doing medicine. But, I don't know, there would have been maybe a couple of doctors in the family, not in my generation, but previously.
Okay.
My mother was a pharmacist.
So there was the medicine around there.
Yeah.
And I suppose an element was a good job, good, respectable profession.
I don't think
I don't
think young people see it that way as a good money spinner. I certainly didn't. I think I saw it as some way of trying to help people, trying to do something practical to influence people's health.
So you go in, you study medicine in TCD. Going back to Patricia, she knew very early on she didn't want to do anything that involved blood. So she was offered the chance to suture up, and she said to the surgeon, "No thanks, I'm never doing that again." So when did you start to develop a sense of a curiosity in one direction, or was it?
Well, I think I was inclined towards practical, hands-on things in medicine rather than, say, pharmacy or giving tablets or that sort of thing. I was attracted to the practical side of it. I think growing up on a farm may have had some influence in that I wasn't afraid of blood. I would have seen animals reproducing and so on. So what turned me towards the field of obstetrics and gynecology didn't happen until the very end. I think I would have been considering something like surgery. And in fact, there was a moment where I'd made a decision to become an obstetrician, and it was during the course of my final examination. And you get, when you're doing your exam, you get a case, you get a couple of cases, you get a major case and a minor case. But the major case that I got was a woman with infertility who was in hospital for treatment, which I had to take her history and present it to the examiners. And for some reason, the two of us formed a very close bond. And she explained her whole history in a very personal way. And I almost became her advocate to the consultant who came along to examine me later and had never met her and knew nothing about her. So I think he got the information about her history from me, and she was sort of encouraging me to get him to understand what her problem was or what she wanted to do. And when that was over, I said, maybe having formed that sort of link or communication, very good communication, I said, well, maybe I could do this. And that's how I sort of turned towards
where did you go to study? What's the next point, the next stage in your education then?
Well, I was a student in Trinity College. I would have been a medical student in the Rotunda Hospital for my obstetrics, and graduated then. And I decided I would see how I'd get on in obstetrics. And it was very hard to get a job in obstetrics as a new graduate because they tended to take more experienced people. Okay, and. I got a job in Northern Ireland, actually, in Belfast, and worked there. And I also worked in Altnagelvin Hospital in Derry. So I spent my first 2 years in Northern Ireland and found that I liked what I was doing and enjoyed it.
Now, we historically have liked to believe that throughout the 20th century that the standard of obstetrics, gynecology, in Dublin, in the great hospitals of Dublin, was very high, and that the quality of care was given. Was that true?
That is true.
That was, yes.
Having worked, I worked also in Britain. I worked in the north of England. A lot of Irish trainees would have gone to England to acquire surgical experience because of very large urban places like Birmingham and so on, where you got a lot of clinical experience. And it would certainly be a fact that if you look at, say, maternal survival in childbirth or the number of babies who are lost during childbirth, figures for Ireland would always have been better than they were in the UK. And they still are to the present day.
What date are we talking about there?
You'd be talking about 1980s, I suppose.
I don't know if it surprises, but we would have been talking about a considerably better funded health service in the United Kingdom, would you? Historically, the NHS?
It's hard to say, but the National Health Service, I went to England to work in the National Health Service deliberately because it seemed to me to be the fairest system. In other words, if you are ill and you require treatment, it should not require your financial resources to do it. It was free at the point of contact is the mantra that drove the National Health Service. It was established in 1948, and it seemed to me to be the fairest and best system, that people didn't have to pay and that the government funded it. I left it after a couple of years. I went off to Africa, but somewhat disillusioned. It didn't work as well as it should. There was a problem with, say, like waiting lists is a sort of a measure of how well things are working, and it didn't work very well that way.
It's a form of rationing, isn't it, essentially,
Yes,
the waiting
yes.
list?
There was a huge administrative presence where you had to make a decision. I remember, it's not a very great example, but if you were working at night and you needed blood for, which is, obstetricians use a lot of blood. You had to ring up a consultant hematologist to get permission to get the blood, and then the person in the laboratory would cross-match it. Now, there was no reason to ring the hematologist except for some sort of trade union dispute that had taken place.
The demarcation lines.
Yes. So you had to ring this poor devil out of his bed. He would say, yeah, go ahead, you can have the blood. And it just didn't seem to be, the clinical needs seemed to be somewhat separated from the way the service operated. And I think that is one of the reasons why our results in obstetrics in Ireland were better than they were here.
The clinician was more empowered to act?
Yes, and of course, one of the differences, I suppose, if you look at the Irish healthcare system, there are two types of hospitals, and probably most people know this. You have state hospitals like Letterkenny, since we're in Donegal, would be a state hospital, and then you have voluntary hospitals, which would be mostly arranged in the cities, but not all. And their background would have been primarily religious, Protestant or Catholic. When I was a medical student, for instance, there were about 8 small hospitals in Dublin, Sir Patrick Dunn's, Dr. Stevens, they're all just historical names now, each of which would have had a speciality. If you had a chest, needed your chest opened, you went to Baggot Street Hospital. Right. If you had venereal disease, you went to Dr. Stevens Hospital. There were different specialties were covered in that way. Now, they've all been amalgamated into larger hospitals. But the background of the voluntary hospitals they were set up at a time when there was no health service, no state health service. Now, the important thing about voluntary hospitals was that they were dependent for some of their funding from the state, but not all. They raised money themselves. But it was given. People gave voluntarily rather than operating within a state system, if you like. You could call it a communist system, as it was in the UK. It was a very interesting thing many years ago. A health economist called Dale Taussig, he was in Ireland, and one of the questions he raised, this is not a very positive story about medicine, but he said, how do you pay doctors? There's 2 ways you can pay them. You can say, okay, we're going to give you a salary, you come in and do all the work, and you get a salary every year. Or the other side was, you come in and you do a procedure, and you get paid for that procedure, and that's the second system. And the problem with the state system where you get a salary is that you have no incentive to do anything other than fill in your hours. So if you do a lot of work, you get the same money as if you do very little work. And I would have come across several doctors in my experience in the UK who did very little work, and they got away with it. So that's one system. The other is you'd say, well then, but we don't want that. We want to pay fee per item. You go in and you get your varicose veins operated on, and the doctor gets paid. There is a disadvantage in that system too. If there are, let's take a hernia, which is a very routine operation. If I can get paid for doing one hernia, let's say they pay €100, I don't know what they pay for a hernia, and there's another patient comes in with an extremely complex problem with their intestine. It's going to be a very long operative procedure, and I'm going to get €100 for that as well, or 200. I'm going to say, well, I can do a lot of hernias and make quite a bit of money by doing a lot of minor procedures. Or you come in to me and your blood pressure's up and I give you treatment. You come back next week, your blood pressure's improved, very good. I think you better come back next week.
Right.
You get the picture?
Yeah.
And maybe the week after, and we just keep an eye on this. So there's a tendency to do a lot of trivial procedures and not concentrate on the very serious cases. So that neither system works very well. So you say, well, what's the answer? The answer, I think, is if a doctor doesn't have a conscience to do the work, to do it properly, to do it conscientiously, if you like, efficiently, and to do what the patient needs, then neither of those two systems is going to work really.
So you're relying on doctors having consciences.
You're relying on a doctor who's got some sort of principle that
Some kind of ethics.
going to do the work, and that he's going to give you, he or she is going to give you the treatment that you require.
Now,
efficiently.
I imagine that your personal ethics, your personal belief system, is in some way connected to the fact that you end up going to Africa, or is it not? Perhaps maybe you just wanted to go somewhere
it was
warm.
A number of reasons, but I suppose I was interested in if you look at obstetrics and look at Africa, that's where all the problems are really, in terms of maternal mortality. The hospital I worked in, I was fortunate enough as a consultant never to see any woman die, but in the hospital where we worked, we would see at least one woman dying in
Where were you?
a month. I was in Nigeria.
Nigeria.
Yeah. And it was run by an Irish organisation, the Medical Missions of Mary and Drogheda, who did unbelievable work in Africa. The doctor I was working with, who was originally from Donegal, actually, Dr. Anne Ward, would have been one of the finest surgeon I've ever seen, and
really?
has a reputation all over Africa for treating what is called vesicovaginal fistula, which is where a woman gets damage to her bladder during childbirth, which is very common all over Africa as a result of neglected labour. And she had a worldwide reputation in treating these women. So I went partly to learn, partly to try and do some service, and it was I learned an awful lot personally as well as professionally.
How long did you stay?
Just over a year, but for 13, 14 months.
Was it a different type of medicine you were practicing? I mean, or was the context basically the same, but just
you're
more
practicing in the same way, but with a much greater disease load. Acutely ill patients. Many of the patients who arrived in were in a sort of terminal condition when they came in. Very great difficulty in getting blood for blood transfusion, which was hemorrhage was a major problem. So availability of drugs was much restricted.
What year is this, sorry?
Early 80s, 1981,
So
1982.
Then you come back to Ireland, is it?
Yeah.
So I'm just curious, if we take a snapshot, in the early 80s is also the time when we have the first referendum.
Yes.
At that moment, if you were to take a snapshot of your profession, particularly obstetrics, what was the culture, the ethical culture of the profession then?
I don't think it was specifically spoken. You couldn't say, I couldn't give you a document that says this is how people practice. It was a sort of an understood thing that you did what you could for your patient. I remember I was...
Sorry, could I break in here, please?
Yes.
Sorry. I know, could we speak up a little bit more?
Sure. Sorry. So I came back. It was the year after I came back from Africa that the amendment took, the famous amendment took place, and it would be correct to say that the vast majority of the obstetrical community in Ireland would have supported the amendment, or would have supported life, and been opposed to abortion. And certainly, when I worked in the UK, my conscientious beliefs about abortion were respected to the letter.
Really?
What happened over the intervening years is difficult to explain in a short thing, but one of the things that did happen was, with the advent of diagnostic ultrasound, more and more babies with fetal abnormalities were being diagnosed. And this was one of the things that may have changed obstetrical opinion, that if somebody has a baby with a serious abnormality and they could do nothing, and they were telling them to go to the UK, the obstetricians went abroad, got this training, which included the termination of pregnancy option and brought that back into the country.
So in a sense, this change in value. It was a fundamental change in the perception of the value of a certain kind of life. If you're going abroad, and in the cases where a diagnosis was made of some kind of a difficulty, a congenital, part of the standard procedure would be to offer a termination.
Correct.
So this attitude is then, shall we say, then brought back into the system here, a little bit, shall we say, like a virus into the system.
Yeah. There was more than that, though. I think there was a fundamental change in people's attitude towards abortion. Say, people growing up or coming into the specialty didn't have the distaste, if you like, for abortion that would have been around in my time.
Of course, doctors come from the wider culture. They don't come ex nihil.
Yeah.
They're coming from a culture which itself is changing in its attitude.
Correct.
But as a practicing obstetrician gynecologist at the time, were you aware of this change happening around you? There was, with younger colleagues, with people coming in.
I was aware of it in the context of what I've just said about babies with fetal malformations.
How did if you came to hear that? Sorry, I'm talking. Say there's a patient presents, and this happens, and you come to become aware of the fact that one of the members of staff is saying to patients, "Well, you can go to England," or "There's nothing we can do. I think you should." As a doctor, as a consultant, do you have a role there? Or how do you manage that?
Well, I remember one particular instance, a woman who had the baby had a serious abnormality. I was working in Portiuncula Hospital in Ballinasloe, which was, it wouldn't be a third level hospital. The patient would be sent for a repeat ultrasound to a centre of excellence, which she did. And she came back. I said, "Will you come back when you have that done?" And she came back, and I said, "Well, how did you get on?" She said, "They told me to go to England." I said, "What do you think about this?" She said, "I don't want to do that at all." She was horrified at this advice. The diagnosis was the same. The diagnosis was the same. And I remember ringing the doctor that she saw in Dublin. And I said, "I'm appalled that the first option you gave this woman was to go to the UK. That you didn't discuss any other option with her, really." And his response was, and she was to go back for a repeat ultrasound to sort of confirm the diagnosis. He said, "Oh, well, I won't say that anymore."
Right.
And I suppose in that way I sensed that people, I don't know whether it's putting it too strong to say that human life didn't mean the same to that doctor as it did to me. And if you said, how did that come about, I can't precisely say.
I don't want to relitigate the referendum, but there were some numbers which came out which seemed to suggest that women in different hospitals where the consultants had a different response. In one case, those hospitals where the consultant's initial response would be to recommend a trip, as opposed to those places where the consultant was dedicated to the idea of supporting the woman through the pregnancy. That there was a massive difference in the percentage of those pregnancies which were brought to term naturally and those in termination.
That's correct. Yeah.
Would suggest, at least, that supported, this is not actually a choice that women are making, but they're being pressured. Do you think that we heard a lot about choice, an awful lot. Do you think that maybe there are doctors out there, perhaps unconsciously, but who are actually putting pressure on patients? That there's a certain economic element, there's an issue there. You're blocking up the system, this is a pregnancy which can never come to term, be practical.
Yeah. Undoubtedly there was pressure, and I'm sure there is pressure being put on patients to terminate the pregnancy. I would have doubted about that. I don't think it was portrayed as an economic case to them. I think it was, I think there was what was being said, even if it wasn't said in words, was, this is useless. This is not going to go anywhere. And sort of, they didn't say it, but you're sort of wasting my time here.
Okay.
And of course, a woman, in my own experience of dealing with them, I've never seen a woman who did not appreciate that I took the baby's side in the argument. I said, we're going to do the best we can. The baby may only live for minutes, may be stillborn. And some of the most precious moments for the parents and for me as a doctor were we're going through this delivery and the, fulfillment or completeness that the couple got from giving birth and caring for this child in whatever way they could. Remember a particular case, maybe I'm too much time, but a woman who had she had a baby with a syndrome. It was a chromosomal abnormality, and she was very supportive to her child, and she wanted the best for it. It was a little boy, I think, and some of those children with chromosomal syndromes, to my mind, resemble angels in their appearance. There's something very special about them. But anyway, the baby was born, very feeble baby, very weak. And she said, I want to put him to the breast. And I said, I don't think that'll work. She said, I want to do it anyway. So I had to go out of the room for some reason, but the midwife came out after a few minutes and come back in, and she showed me the child feeding on the breast. He lived for a few days. But I said, that's amazing. And she said, I tried to tell you this last week, but you weren't listening. This is what she really wanted to do, and she was so happy that she was able to do that. That she'd achieved that. It was almost as if a whole lifetime came in those few minutes, So there are precious moments that arise in those situations where if you cut it off and you don't grieve, you don't go through the process of burial or introducing the child to the other children in the family and so on, that are lost, that cannot be good for a woman.
Today, we face the new reality. You said you referred to the fact that when you were in the UK, your conscience rights were scrupulously observed.
Correct.
Do you think that doctors and nurses and other people in the profession in Ireland will have the same sensitivity shown to them? Are the same level of conscience rights available that you experienced in the United Kingdom?
I have a feeling that it's not the same in the UK now as it was then. And I think for now, conscience probably will be respected. As time goes by, that may loosen. And again, I talked earlier about administration and people who run things rather than are directly involved with the patients. There may come pressure on people from outside to do things that they don't want. The thing that disturbed me most about once the referendum was over was the lack of respect for conscience, which was clearly rejected by the legislators. That if a woman presents requesting an abortion, and I say I cannot do it, that I have an obligation in that circumstances to refer the woman not to another doctor, but to another doctor who will complete the deed.
It. Yeah.
That makes me complicit in the act. And it's the same as driving the getaway car in a robbery. You're guilty. And I cannot really understand how people would find that a reasonable thing to expect a doctor or a nurse to do. It just seems so wrong, so disrespectful of their position, their ethical position.
We'll finish up and just on. Imagine it's the young doctor Monaghan just graduated and facing into the profession now. Would you still go into obstetrics in the Ireland of today, or would you look elsewhere?
It's impossible to answer that question.
Of course.
One of my sons did medicine, and when he graduated, I said, what are you going to do? He said, I'm sorry, Dad, it's not going to be obstetrics. And ever since the Abortion Act came in England in 1967, there has been a shortage of obstetricians. So I predict a shortage of obstetricians, that people would not be attracted into the specialty. Certainly when I dealt with medical students in the UK, not one student that I met in my time there was interested in doing obstetrics. And when you asked them, it was because of abortion.
Really?
So that's going to be a fact, I'm sure. That may lead to a fall in standards, I'm afraid. So would I go in? Perhaps my stubborn character might make me want to do it again, but it would certainly. I am so happy that I was able to spend my professional life without having this abortion issue as a daily incursion into my care of patients.
Thank you, Dr. John Monaghan. I'd like to thank our audience here in Ballybuffet for their kind attention. And I'd like to say again, thank you very much, Dr. Monaghan, for, I think, a fascinating insight into the life of the doctor.